Good afternoon, everybody. Thank you so much for this opportunity. So I begin with a picture of a girl hiding behind the podium because I'm quite worried that could be my case at the end of the presentation, but then here I go. Refractive procedures can be laser vision correction, but then they come with the limitation. Okay, sorry. Okay, so laser vision correction, but they come with a limitation in the amount of refractive correction that can be safely treated. So then came the phakic IOLs to help us out there. So once upon a time, in the year 2017, a 22-year-old boy came to us wearing glasses, wishing for LASIK. He said if he got rid of his glasses, that would really make him happy. So when we examined him, his vision in the right eye was 660, left eye 612. Rest of the examination was within normal limit. And this was his refractive error. Now we realized that LASIK wouldn't be possible for him, so we discussed that he could go through ICL and that would take care of the problem. He could get rid of his glasses that way. He agreed for the same, so we did a IOL master white-to-white measurement and a manual white-to-white measurement. As per plan, we went ahead with ICL in both the eyes in October of 2017, a week apart. Toric ICL was implanted in both the eyes, but then the problems began. The vault size in the right eye after the surgery was 60, and over the years from 2017 to now it has varied from 60 to 207. His vision had varied from 612 to 624. Looking at the left eye, we at least began with a 186, but then through the years it has varied from 62 to 220. Vision also varied from 612 to 618. So he landed us up with a lot of questions that should we rotate or remove this ICL? Will he develop cataract? Why does his vision vary every visit? And what is our plan now? Now the ideal lens vault should be approximately 250 to 750 microns. And in his case, as I said, the lens vault varied from 60 to 207 in the right eye and 62 to 220 in the left eye. So the lens vault has never been more than 250, the minimum basic requirement. The patient was informed about the situation and explained the possibilities of developing cataract. Now what are our options? To wait and watch, to explant, to rotate, but then it's a toric ICL. So will he develop cataract? Well, he may or may not. So far he hasn't. Should we rotate or remove the ICL? In 2017 and since then in all his follow-ups, the patient was always explained the possibility of developing cataract. He has always preferred to not have any intervention unless any complication develops. He has always been comfortable with his vision and still happy without his glasses. We have always kept the patient on close follow-up. Why his vision varies every visit? On dilated examination, we noticed that the ICL has rotated in the right eye from 7 degrees to around 50, and in the left eye from 18 to about 100. Since it's a toric ICL, the rotation results in the variation in his vision. The rotating ICL tells us that probably the lens implanted was of a smaller size and hence it is spaced to rotate. The smaller size also explains the low lens vault. What we consider boon and bane is his power being more of spherical nature, vision is nearly maintained. The vault has formed with more vertical rotation of both the lenses. Points we learned: the vast difference in the white-to-white measurement of IOL master and manual measurement using calipers should have prompted us to check again. We should have checked vault size after the first eye to get a clue about the problem with lens sizing before doing the second eye. 5 years since his ICL implantation and there is no cataract development in spite of low vault size in both eyes. With the ICL rotating to more vertical orientation, it seems to be autocorrecting the vault size issue. But then we are aware that it can still keep rotating and come back to a horizontal position. So we plan to continue to monitor the patient in close follow-up. Thank you.
Thank you. I just have one question. What was the size of your ICL? That was 11.05.
Yeah,
and what was the size? Because what did you base it on? On the manual?
We based it on the manual. We based it on the manual.
Normally, if it is 11, they give 12.5. 12.6 they give. 12.6 they give. Yes. So that's what you put in?
It is, yeah.
12.6.
But
so because it was a high myo, probably he had deeper sulcus. And that is a big problem. And sometimes, even though we try to do our best, I also had one patient who rotated constantly. And there was not so much of varying of power. Only thing, it used to come down just by one line. So I rotated it twice. And then she decided that she'll just stick to this and just leave it alone. But there are some anti-segment OCTs which can actually measure your sulcus depth. So that gives us a better idea about the overall white to white that we are supposed to implant. But most often, even I go by the digital caliper. That's what you used, isn't it?
Yes.
Digital caliper is probably, I think most of us use. OpScan used to be pretty good, but nobody uses OpScan now. All other parameters, because they look at the, it's more of an imaging system. They look at the color of the limbus, so it can actually be can mislead us.
We did a study on comparing the white to white diameter about through manual and the different 3-4 instrument, Pentacam, IOL Master, all of that. But none of them actually come. There's a lot of variation between the manual measurement and the other instruments.
Topolaser Vario is okay. I mean, it is a little bit closest of all the other parameters which you have checked. Anyway, it's a good case.
Thank you. Thank you.
So the most reliable is topolaser?
No. Digital caliper is the best. Yeah, but this, see, once in a while, very rare case when the sulcus is very deep, you can come across a situation like this. So it's very, if you see a very low volts, that is the reason for it. But the other important thing is if you have a very deep AC, like it's beyond 3 millimeters, it's better to oversize it even beyond that.